Oh, okay, here we go. Okay. Hey everyone, I'm here with Dr. Centeno, founder and chief medical officer at Regenx. We're sitting here in headquarters, and we're going to take questions. But today I thought I'd start by asking you, what's new in the regenerative medicine world in the last couple weeks since we spoke last?
You know, probably the newest thing would be Google's decision last week to ban stem cell advertising. So, you know, the space has gotten so out of control with so many crazy chiropractic, naturopathic, alternative medicine, anti-aging clinics offering these therapies that are really concerning to folks like Google. So they're shutting it all down as of October 1st. So you'll no longer see any stem cell advertising on Google as of October 1st. So that's an interesting one because it really highlights, I think, how out of control this space has become. And as you probably know if you read the blog, I've been a really big critic of what I call the stem cell Wild West, and turns out Google is as well.
Yeah, right. And so how do you think that will affect things moving forward for people?
You know, I think it's it's a two-edged sword. There's a good part and a bad part. The good part is that we'll see a lot of the clinics that are predatory really have their their digital reach curtailed by quite a bit. On the
plug. Hold on, folks. You can keep talking.
On the bad part, I think what we'll see is, we will see fewer people be able to find what it is they're looking for. So that's the hard part, because Google also recently did an algorithm update in April that really de-emphasized a lot of non-traditional things in the search algorithms. So it was really interesting to see that it's just getting harder and harder for people to find information on this topic.
Right. I've seen some big numbers change in people's, with that algorithm change, trying to find what they're looking for. All right, we're just getting, here we go. All right, so if you've got questions, please let us know what's going on, what questions you have that we can answer for you with regards to regenerative medicine and Regenx. I also want to recommend that if you know somebody who is suffering with some sort of musculoskeletal complaint, some pain, some discomfort, please share this with them. Could be a loved one, someone you work with. Let them know that there are other options out there, especially since it might be getting harder for them to find solutions to their problems. Let's see here. Does the initial stem cell count that is harvested have an effect on the ending count for cultured stem cells?
It does. So, like anything else, more cells in means more cells out. So if you're culturing stem cells, which we can do down at our licensed site in Grand Cayman, where that stuff's allowed, it's not allowed here in the United States. If you get more stem cells on the harvest, you will end up with more stem cells after growing them. So just as important to do a really good harvest there as it would be if you're doing a same-day stem cell treatment.
And I had some people come through the clinic today. We were talking about dosing. Can you address that? Because they had not heard this ever before about the cell dose.
Yeah, so we've done some research, and others as well, not just us, have looked at the concept of whether or not there is a cell dose, meaning that do you need a minimum number of stem cells or other cells to make these procedures work the best? And the answer is you do. Now, the problem is there's a couple different ways to get to that dose. One way requires that you culture out the cells and look how many colonies are forming. Obviously, that's not real practical because you can't use that at the bedside. That takes like a week to even get an answer. So that doesn't help you with dosing a patient clinically. And then the other thing that we figured out is you can use the total number of cells that are counted as a proxy for the number of stem cells. So that's what we tend to do. And so we've come up with dosing guidelines, but you have to count the cells. And if all you do is use a little bedside centrifuge, there's no way to count those cells. You have to have a lab set up to count the cells, and we do in all of our sites. That's one of the reasons why we require a lab set up and not just a little bedside centrifuge, because we want to know that dose. There's nothing else in medicine where you don't know the dose. Dose is a critical concept in medicine, other than in most stem cell clinics, 99%, where they have no idea what the dose is they have or what is the dose is that they need.
Right, and while more questions are coming in, since we're talking about stem cells and dosing, I know you've written about this in the past, but what can people do to ensure that they get as high of a yield out of their body as possible?
You know, diet, exercise are two good ones. So we have a whole book that we've written on proper diet, exercise and being as active as you are able to be. And then we have actually seen some interesting stuff with the stem cell support formula. We spent about a year researching that in the lab, which is very, very unique for a supplement. No one does lab research for a supplement, but we did. And so we've seen anecdotally some really interesting things with stem cell numbers going up. And then there's obviously doing a really good draw. I mean, there's no substitute for the doctor taking extra time to get more cells versus putting his convenience over the number of cells that he can get.
Great. So here's a question about the CCJ procedure. How long would an international patient need to be in the U.S. If all prerequisite procedures have already been done?
You know, we would ask that an international patient come in usually the day before. Then they'll be seen that morning for the evaluation. If additional studies need to be done, you might need to come in another day earlier so you can get those studies done here, like a digital motion x-ray. And then the procedure would occur, the bone marrow aspiration in that morning, the reinjection procedure that afternoon. And then I'd expect an international patient to stay at least a few days so that we can make sure there are no issues, problems. If there are any issues and problems, we can bring the patient back in and do a thorough evaluation. So we'd want a few days before that person went home at the very least. In addition, if you're an international patient, we always recommend that you buy a short-term travel type U.S. health insurance policy because, you know, as you know, health insurance is different here than it is in Europe or elsewhere. So you're going to want to make sure you're covered in case there's some potential problem or complication. Now, the good news is we haven't had any issues like that with this procedure, but it's a relatively new procedure, and so I know that it's safer, for instance, than a cervical fusion, but I can't tell you how safe it is in 1,000 patients because we've not gotten there yet.
Right, great advice. Gabby asked, in the apical ligament, is the apical ligament easily accessed during the PICL?
Yes, the apical ligament can be treated if we need to get to it. So in the traditional PICL procedure, we're going through, if you see here, this is actually a large version of the atlas and the axis, so C1 and C2. The head would be up here, and these are much, much larger. These are about 4 times their normal size. The traditional PICL procedure goes through this little hole here and here between C1 and C2. In order to get to the apical ligament, we would have to go over the atlas in this direction. And that's something we've just started doing here in the last several months, is doing more work above the atlas in addition to below the atlas between C1 and C2. So that's a relatively new facet of this procedure.
That's great. Here's a question on high blood pressure with no ACEs help also increase stem cell counts. That's a question.
High blood pressure, meaning there's no ACE inhibitor medication being taken. Yeah, I think what you're getting at is that we have seen that ACE inhibitor medications, like lisinopril, for instance, which went to generic about 6 or 7 years ago, can, for whatever reason, seem to hurt stem cell counts. No one's 100% sure why that is, but we definitely saw a pretty significant association there. So if you've got just mild high blood pressure, we want you off of that ACE inhibitor medication. And then you can go back on, obviously, a few weeks after the stem cell procedure. If you've got severe high blood pressure, you obviously need to be treated and monitored. So you can either change to a different medication, or if that's not possible, you may need to be on an ACE inhibitor. We've had that happen, but obviously we would want to work with you and your doctor on those.
Someone asked about how you would treat a shoulder with calcific tendonitis that was noticed on an MRI.
Yeah, interestingly enough, calcific tendonitis, well, let's kind of back up a little bit. So that means that there's an area of calcification in the tendon. Now, most people think of that as like a piece of bone that has grown into the tendon. In actual fact, most of the time it has like a toothpaste-like consistency, or maybe a hardened toothpaste type consistency. So it can usually be broken up with a needle pretty easily. So any regenerative procedure we would do would break that up during the procedure under ultrasound guidance. Now, on the rare occasion that it can't be broken up, and that's maybe only a few percent of the time, it might need to be surgically removed. That's very, very rare. More likely, we would use something like a percutaneous tenotomy, which is a little device to break it up, but that's usually not required.
All right. We're going to jump back and forth here. Is there any rehab for the PICL procedure afterwards?
Yeah, the biggest thing to do with the PICL procedure initially is to keep the joint in proper alignment. So if the patient responds well on a temporary basis, for instance, to upper cervical adjustments like NUCA, then we'd want them to continue those. Then once they get strong enough and able to tolerate physical therapy, because that's a big deal for many of these patients, they're just not able to tolerate it. So once they get to the point where they can tolerate more activity, then we will have some specific rehab recommendations for them to start working on.
That's great. Let me bounce back to the blood pressure medications. A different one, Candesartan. Have you heard of that? I don't know what that is.
Candesartan. I'm not an internal medicine doc, so I don't prescribe these things all day, and new ones come out all the time.
Right, exactly. That's Candesartan.
Yeah, so it is different from an ACE inhibitor. So that's not one that we know of that's a bad actor at this point. That's not to say it might not have some effects, but it's not a known bad actor.
Do we treat sternoclavicular joint injuries?
We do. In fact, sternoclavicular joint is an interesting one because it's kind of like no man's land. Patients are often frustrated. They've got pain in this area here where the clavicle comes to meet the sternum. And oftentimes it'll be identified by a high-quality manual physical therapist or a chiropractor who will understand that it's loose or lax and adjust it and make it feel better temporarily. But the ligaments that surround that sternoclavicular ligament are usually what needs to be treated. It's really common in car crash type injuries where you've got a seatbelt coming over that area, for example.
Right, while we're talking about ligaments, do you inject the TMJ ligaments? Do you require an MRI beforehand?
Yeah, for TMJ, it's nice to have an MRI, but we can also look at it somewhat under ultrasound. It's not a joint under ultrasound that's easy to image, but I also can't say that the MRI findings are that important to us, meaning that it's more clinical exam findings with the TMJ, because we've seen very severe TMJ treated with stem cell injection precisely into the joint and then into the surrounding ligaments. And we've seen those patients do well. They go from not being able to eat solid food, for example, to eating smoothies or soft foods, back to eating solid foods. So it's interesting that that's a joint that, despite severe osteoarthritis within the joint, if you fix the instability component, they do pretty well.
Bouncing around again. Now, how long would you have to be off blood pressure medication? I think you addressed that earlier, but...
Yeah, we would generally look at the half-life of the medication. So as an example, many of those medications are usually twice a day or once a day. So if it's a once-a-day medication, the half-life's a bit longer. Usually the half-life is usually around 12 to 24 hours. So you'd have to be off of that stuff longer, usually 3-4 days. If it's a short half-life medication, sometimes only 1 or 2 days. So we would just look at that half-life, and usually it's about 3 to 4 half-lives that you want to be off the medication. So if you look it up online, if you just type in the medication name and half-life, it will tell you that. And let's say it's 12 hours. So if it's 12 hours, you'd want to be off it a solid 48 hours plus prior to the procedure. If it's 6 hours, you might only need to be off it for 1 day.
You know, I see this a lot around with other people doing this, where they treat everything all at once. And here's a question. Can you do both shoulders, C1 through T4 and L1 through L5, all in one visit?
You know, we can. You know, certainly don't like when people try to treat ALS and multiple sclerosis and impotence and knee arthritis and anti-aging and all that stuff. I think that's a little bit cray-cray. But when it comes to treating different areas of the musculoskeletal system, we do that all the time. And it's just going to depend on dose. So if we're doing platelet-based procedures, we can usually treat many different areas. If we're doing same-day stem cell-based procedures, then we'll have a dose that we need. So that might limit the number of areas. And if we're doing a culture-expanded stem cell procedure where we're growing those cells to bigger numbers, we can treat, again, a lot more spots. So, but we routinely treat patients with multiple areas.
Got bumped off here. All right, we're back. Stacy asks, she did a lot of hurricane prep, and after PICL, you probably recall her, and she's a little sore. Did she undo it, or will rest help?
You know, probably rest will help, would be my guess. I would have to know more about the clinical scenario and when you got treated. But, you know, normally what happens is that you go through an inflammatory phase in the first week or two. Things are tighter. Sometimes they'll feel better during that time. Then you'll go through a donut hole phase, usually where the body is just starting to lay down new tissues. And then at around the 3 to 4 month mark, the tissues have all been laid down and they're remodeling. So really, once you get to about that 6 week mark, the tissues have been laid down, and it's just a matter of the body remodeling those tissues.
Ivy says, thank you for all you're doing and to enhance people's lives.
Oh, thanks, Ivy. I know which Ivy. I think you're the only Ivy I have as a patient. That's not a super common name. So thank you for that. Let me know if I can talk about your story here, because you've got a pretty interesting story to talk about.
That's great. Carol asks, if an MRI shows problems like bone marrow lesions or osteonecrosis in a knee joint, should stem cells be done ASAP even if there is no pain? Yeah, for avascular necrosis, that's an interesting one. So let's kind of back up a little bit and describe that. So avascular necrosis or osteonecrosis means that the bone is dying. And regrettably, it's not the kind of thing that usually gets better on its own. Every once in a while it will, but most of the time it progresses in one direction, which is towards collapse of that bone. So if it's detected on MRI, even though there isn't a lot of pain, it probably needs to be treated because once the bone collapses, all bets are off. So that is something that we would tend to treat with an intraosseous, meaning in the bone, X-ray guided injection, even if the patient didn't have a lot of pain.
because we don't want it to progress so that the bone collapses.
Right. Here's one, and it seems to be complicated. Peptides are becoming popular. Do you know of anything that's effective with joint pain?
You know, I don't. You know, we have good research on things like curcumin, fish oils, glucosamine, chondroitin. Those are all things that have some really good, solid clinical research, big studies, randomized controlled trials showing they work, showing they're as effective as things like nonsteroidal anti-inflammatory drugs. Peptides, not so much. I think you're going to see a lot of animal research. You're going to see a lot of in vitro, meaning lab research, but not much human stuff at this point.
Right. Now we've got a few more minutes, so I want to ask if there's more questions, let us know. Ivy, let us know if Dr. Centeno can share your story. I also want to recommend a couple things. If you know someone who would like to hear more about this or would like to know about some options other than surgery or maybe medications they're taking, please share this with them. If you're looking for a provider near you to give you specific answers for your condition, go to the Regenx website at regenx.com and you can find a physician near you. Let's see. Coming in, hold on, shoulder question. Unfortunately, I'm not seeing all the comments here, but shoulder osteoarthritis with joint changes and tendon changes. How would you treat something like that?
Yeah, what's interesting about shoulder arthritis is that we've been pleasantly surprised. So with some of the more hip arthritis patients, those patients can be difficult to treat without using some of the cultured cells down in Grand Cayman. But for shoulder arthritis, we've been pleasantly surprised with a same-day US-based stem cell treatment for that. And I think it's because a lot of the pain there comes from damage to the rotator cuff. So we can really get in there and heal those small tears in the rotator cuff all day long and twice on Sunday. And even though we're not regrowing the person a new shoulder joint, much of their functional pain goes away. So I've been fairly impressed with our ability to help even severe shoulder osteoarthritis patients get more functional.
Great. Someone asks, would this be helpful with coccyx pain after the coccyx has been removed? They apparently had a nerve block which helped, but that's a good question.
Yeah, that's a hard one. You know, the coccyx is that little bone at the bottom of your tailbone, and it does serve as the anchor for a number of different ligaments that come off of it. So by removing it, we've changed the biomechanics a bit. Now, it's certainly possible that the coccyx itself, if you're still having pain, was never the cause of the pain to begin with. And so, for instance, we'll see overlay there with lower sacral nerves causing the pain. So something like a platelet lysate epidural that's delivered caudally through into those lower sacral nerves may be helpful. And or looking for other causes of pain in that coccyx area. Because if they removed the bone and they thought it was the bone and the pain didn't get any better, then it was never the bone.
Let's see. Someone asks, Stacy, can I wait a year between PICL procedures to avoid snow without compromising progress, or should I come back sooner?
Yeah, I mean, that procedure, if we look at ligament healing on big ligaments that we can see very easily, things like ACL and the knee. In older patients, and I'm talking middle-aged patients and older, you'll see changes that really continue through 9 months. So we'll see that the ACL in an older patient looks better at 3 months, and then it looks a little better at 6 months, and it looks really good at 9 months. Now in younger patients in their 20s, at 3-4 months it looks great. So it's good to be young. But so I wouldn't be too concerned about waiting a year, because we know that ligaments will continue to remodel through that time period. Now, what patients tell me with the PICL procedure is usually that 4 to 6 month mark is where they're getting a lot of progress.
Terry Velasquez.
Oh, hey, Terry.
Yeah. Her son was one of the first study patients, an avid hunter, and today is still doing great. Thank you.
Oh, well, Terry, great to hear from you. It's good to know that Josh is doing well still. He was one of the first study patients, back in like 2007 probably. So he's probably 12 years out or so from his procedure. So that's great to hear.
Yeah, that is. Kathy asks, she had a stem cell procedure in her knee about 2 years ago, and it's starting to feel a little sore. How long should the results last?
Yeah, so for knee stem cell procedures in responders, we're generally seeing 2 to 7 years. So you might be one of those patients that needs an update treatment, and I would probably get in sooner rather than later. Now, sometimes just a PRP shot will push it down the road another year or two. So you might want to try that because that's obviously less invasive, less expensive. But 2 to 7 years is kind of the time frame. So you could be on the shorter end of that range.
Let's see here. There's a good question about antibiotics. Have we studied antibiotics with any of these procedures? Looked into that?
We have, yes.
Can you tell us what you've noticed?
So quinolone antibiotics, ciprofloxacin, floxin, things like that, those are a problem. And we know, for instance, that they're involved in tendon injuries. And that seems to happen at least in part through mesenchymal stem cells and in part through tendon progenitor cells. So not a good idea to be on those types of antibiotics in these procedures. Higher dose gentamicin can be a problem as well, but lower dose gentamicin is not. So those are the things we've noticed.
Stevie asks, how do you discern how to choose a doctor to do this type of procedure in the knees, and how long should one wait degeneration-wise for a stem cell procedure?
Yeah, that's a great question. I've got a whole book, a little tiny book I wrote. Last time I came back from Grand Cayman, I was on a long flight. We had a big layover or delay or something. I think we had to stop someplace. So I had a lot of time. So I wrote a little 12-page book on that topic. So that's on the website, or Carol can get you a link for that book. But the bottom line is you want a doctor that has specific training in this area, and that's really hard to find. That's one of the things we do well at Regenix is we look at our doctors from the standpoint of what their basic training is and what they know. We tell most of the guys that are interested you're not qualified, so we take a select group. Then we make them go through nonprofit training through the Interventional Orthopedics Foundation. Then we make them go through specific Regenix training, and all of them are therefore much more trained than the average guy doing this work out there. So that's one way to find a good doctor. Another way to find a good doctor, if you don't have someone that's on the Regenix network close to you, is go to the Interventional Orthopedics Foundation. That's interventionalorthopedics.org. And you can ask those guys. They will have people who have taken the courses there that may not be Regenix physicians, but those people I would trust as being trained. And then as far as letting the knee go, I think you want to get it treated as soon as you can, because I think it's better to treat small problems when they're small rather than wait till they're big.
Yeah, good. Let's bounce back to antibiotics, doxycycline. That's an antibiotic, right?
Yeah, doxycycline should not be a problem. We've tested it with cells. The cells don't have any issue with it. In addition to that, it bumps up what's called transforming growth factor beta in a joint, which is a good thing. In fact, early on, the Europeans thought that our arthritis may be caused by bacteria because they had put people on doxycycline and their arthritis got better. They later learned that the doxycycline was acting directly on the arthritis through that growth factor rather than treating a bacterial infection. So doxycycline is actually a good actor here.
Would a stem cell procedure in the disc help rehydrate a degenerative disc?
No. Well, the answer is not reliably. So we have seen in some patients the cultured cells that we offer down in Grand Cayman can rehydrate a disc. So the answer is it's possible, but it's not a reliable finding.
All right. Holly asks, do you have a lot of success for spondylosis? How much recovery time will my college soccer player need?
Do you mean spondylolysis or spondylosis? Spondylosis is degenerative disc disease. Spondylolysis is when there's a crack in the vertebra, and that's kind of more common for a college kid age group. So I'm assuming you're going to mean spondylolysis. So yeah, we've treated spondylolysis. That's where there's a crack in the vertebra. A lot of times there was a weak area and it got cracked during activity, or sometimes it just was born not connected. So if it's the kind that was weak and then cracked, those do well. The recovery time there is they do need to be in a brace for 6 to 8 weeks because we are treating basically a fracture. So it's a little bit like treating any other fracture, but that's a specific injection of stem cells into that tear under X-ray guidance, or not that tear, but that break in the part of the vertebra.
Gabby, I'm getting to your question right now. You've been persistent. Is the apical ligament part of the PICL procedure? Or is that a case-by-case basis?
Yeah, it's case-by-case basis. We can access it. It's not one that's typically injected in the PICL procedure, but if there's a rationale to inject it based on the imaging studies, we're happy to inject it. It's not a problem to get to. It's more a risk versus benefit type thing.
How would you strengthen the multifidus muscles in the neck after a car crash? I send people to YouTube.
Yeah, I think that, so there's two components to that. The first component is obviously trying to strengthen. So there are exercises out there like deep neck flexor exercises that can strengthen the little muscles up front. Then there are just common range of motion exercises which can help activate the multifidus in the neck. And then there are actually even strengthening machines. There's one called the multi-cervical unit that can take it to the next level. And then there's a whole bunch of exercises in between. Now, for some patients, those muscles won't strengthen because the nerves are irritated and the nerve is shutting down the muscle. In those patients, we would tend to inject some of their platelet growth factors around the nerve to get the nerve back online and then send them for rehab. So it just depends on whether or not they respond to rehab only. And for some patients, that'll do the trick, and some patients not.
All right, well, we're going to wrap this up at this point. Kenny, I'm sorry we didn't get to your question, but we will get that answered right away.
What's his question?
I can't seem to find it. You want to repost that, Kenny, and we'll take a look at it? For some reason, they're all not showing up here.
Is that right there?
Will this work for severe spinal stenosis in the neck? No, this is someone else.
The answer to that question is yes. We've seen it work for spinal stenosis in the neck. I've actually got pretty significant spinal stenosis in my neck. So I can tell you that one from personal experience. If you look on the blog, you'll see several examples where it's worked for patients with spinal stenosis in their neck.
Does an iliolumbar ligament injury respond well to a PRP injection? Kenny, I'm waiting for you.
Yes. So iliolumbar ligament injury responds well. In some patients, you can inject it with ultrasound guidance based on how thin the patient is. In other patients, you need to use X-ray guidance, and in that case, but either way, we can inject it and it would respond well.
So Kenny wants to know if there's not regrowth of cartilage in the shoulder and it's bone on bone, one, will it help, or two, will it continue to hurt?
Yeah, so Kenny, it depends a lot on what's causing the pain. So we do see patients with shoulder osteoarthritis who have a lot of pain coming from the joint. And the problem with the joint isn't so much a loss of cartilage as it is that there's change in shape of the joint capsule is tightened down around the joint, and the tendons are all ripped up. So for most patients, we're seeing that even though we're not regrowing them large stretches of new cartilage in that joint, we are helping that tendon pain, we are getting rid of the joint pain, and we are improving their range of motion through other means, meaning we do things like capsular distension to blow out the capsule and stretch it so they can move better. But it's not working through regrowing new stretches of cartilage. It's more working through those other mechanisms.
All right, great questions. A lot of good answers here tonight. A lot of good stuff going on. So again, if you know someone that needs to hear this, please share it out. We'll be back in a couple weeks. Any final words there, Doc?
Yeah, final words. It's crazy out there. I always say this, but I tell you, it gets crazier every week. I see something else. I've kind of stopped blogging on it as much as I used to, because at first it was cathartic and then it was an obsession. So I've kind of moved on from obsessing about the craziness, if you will. But yeah, it's crazy. So just be careful. Do your homework. Do your reading. That's one of the great things about a lot of our Regenix patients is that they do their homework and they see pretty quickly the depth and breadth of information we have out there. So do your homework. Make sure that there's more than just a pretty website. One of my favorite things I like to do is I like to do reverse address lookup. So get the address for the clinic that's on the website and just copy and paste that into Google and search that, and you'll be all surprised all the stuff you find. You'd be like, God, I thought this was a stem cell clinic. No, it's really so-and-so's acupuncture clinic or whatever. So just be careful out there. Have a great week, and we'll see you back here in 2 weeks.
All right, thank you.